Good afternoon and welcome to the Institute for Global Health Sciences Grand Rounds. Today we have I'm Dr. George Rutherford. I'm the acting executive director of the Institute, and today we have a special treat. Triveni DeFries, MD, MPH, is an assistant professor in the Division of General Internal Medicine at Zuckerberg San Francisco General Hospital in the UCSF Department of Medicine. There, she co-directs the UCSF Human Rights Clinic, where she performs forensic medical evaluations for people seeking asylum in the United States and teaches learners and clinicians, including second-year medical students, such as Alice Liu and Nathan Koss, who will be speaking with her today. She serves as the Director of Education and Training for the UCSF Human Rights Initiative, and her special interests are in immigrant health, human rights, and addiction medicine. I'll just say before I turn it over to Dr. DeFries is that we'll be taking a break in August, and then we'll reconvene on September 14th, where Andrew Medina Marino of the Desmond Tutu Health Foundation at the University of Cape Town will be presenting. And then hopefully we'll all be back in person. So we look forward to seeing you in September. Thank you very much, and take it away, Dr. DeFries, and thanks again.
Thank you so much for that introduction, and welcome to our talk. My name is Triveni DeFries, and I'm really honored to present today with two UCSF medical students in kind of a unique presentation on the global health clinical and training work that we're doing with asylum seekers locally here in the Bay Area. We have no financial disclosures. And today we're going to introduce you to the work of asylum medicine and expand your awareness of how clinical and other skills can be used to advocate for asylum seekers. And our students are going to demonstrate interactively, while using a case, how they learn to use trauma-informed strategies in this work. And we hope that you leave this presentation feeling inspired to explore how an academic institution like UCSF can catalyze change in refugee and asylum seeker health, and really appreciate the impact that our health professional trainees can bring. So let's start by orienting you to the need that we are all facing while living in a time of record forced global displacement. So to appreciate the magnitude, consider that with 272 million international migrants today, if international migrants were one country, they would be the 5th largest country in the world after China, India, the US, and Indonesia. So it's really imperative that we examine the health of our populations and our patients in this broader context. And what we know is that hundreds of thousands of refugees and asylum seekers attempt to enter the US, as you see in the media all the time, and come to places like the Bay Area in search of safety. And this search is at an all-time high as a result of violence, evolving US immigration policies, and increasingly due to climate change. So people are on the move around our globe for a number of reasons. And I want to focus us now back from the whole world to our world here in San Francisco. And everyone in the audience can think about the last time they took care of a patient with a migration story, or maybe reflect on your own migration story to bring us home. And I'm going to talk about how, amidst this crisis, we've developed a program where we at UCSF can contribute on an individual case-by-case basis to really drastically improve the lives of displaced people here in San Francisco. And as a clinician who's trained at UCSF, I can attest that many people like me go into medicine or into public health with a mission of impacting these humanitarian crises, but often stumble to find ways to apply our skills towards meaningful global and local impact. And so I'm honored to present this to you today as global health colleagues to discuss one example of how we can do this at UCSF. And to understand who are asylum seekers, the focus of our presentation today, let's review some definitions that we hear commonly. And it's important to distinguish these terms because there are legal differences between them. So a migrant is someone who leaves their home country, often to seek economic opportunity or increasingly due to climate change, but is considered to have no impediment to returning back home and would have the protection of their government if they did so. Whereas a refugee is somebody who has fled human rights violations or persecution in their home country and has a reasonable fear that returning would be unsafe. And they have been granted protection status by international law to be in the US. An asylum seeker is someone who has, similar to a refugee, fled persecution, but is inside the US or at one of its ports of entry and has applied for protective status from the government. And then those that are granted asylum are referred to as asylees and are allowed to remain, and they're given certain rights that refugees are given. So seeking asylum like this is a human right, according to the Universal Declaration of Human Rights. But to get to the safety that asylum confers, the asylum seeker bears the burden of proving that they meet this criteria here that is set forth in the 1951 Refugee Convention. And the cornerstone of the asylum process is to prove that a person is unable to return and be protected by their country because of their race, their religion, their political opinion, nationality, or their membership in a particular social group, which means and is defined by the UNHCR as belonging to a group with common characteristics like a family or LGBT status. And this is the group that increasingly is used in US law to accept cases involving domestic violence. So as many of you know, US immigration and public health law has very systematically dismantled asylum in the United States over the past several years and reversed many of the protections that have been in place since World War II. And asylum seekers have faced mounting challenges in the past several years. But for those who do manage to go on to pursue an asylum claim in the United States, most do not have legal representation to help prove this well-founded fear of persecution. And only 15% of asylum seekers will be granted asylum without an attorney, whereas 45% will go on to win their case with attorney representation. And then one study found that asylum seekers with a medical evaluation performed by a healthcare professional were granted asylum at about 85% of the time. That's nearly twice the national rate. So we in the healthcare community are uniquely positioned to help here. A medical examination written into a legal document called a forensic medical affidavit can contribute to a successful asylum claim by documenting the effects of persecution that they've experienced. And this can provide the compelling evidence needed to make the case for asylum. Many fleeing persecution only have their narrative accounts, their stories, and the scars on their bodies and minds to attest to the horror, the persecution that they've endured. And so healthcare professionals here can provide, as I said, the objective documentation of physical injuries and psychological symptoms as evidence to corroborate that story, that narrative. And in this role, healthcare professionals are acting slightly differently than their usual capacity. So for the clinician, they are the expert witness here, rather than the provider of routine medical care. They're documenting in a legal manner, not in the electronic health record, for example. So based on this role in medicine of examining asylum seekers, a new field has started to coalesce called asylum medicine. And this brings together a community of professionals who conduct these medical and mental health forensic evaluations of asylum seekers. For example, in 2021, the Society of Asylum Medicine was formed, and this year in 2022, the first textbook in asylum medicine was released. So this is a nascent field, and it's formalizing right now in this moment. And clinicians and their partners across the country are performing these medical evaluations for asylum seekers, nearly always on a pro bono basis, and especially at academic medical centers. So recognizing this impact and this need, we founded the UCSF Human Rights Clinic with students and faculty in 2019 to expand access to forensic asylum evaluations in the Bay Area. We have volunteer psych and medical clinicians who perform assessments that take about 3 to 5 hours at our monthly clinics, and they evaluate the impacts of trauma and persecution that an individual has suffered, documenting scars or PTSD. And medical students help to coordinate the clinic. They take referrals from local legal organizations, and they participate in an elective and in shadowing and evaluation. So today we have the great pleasure of actually showcasing how medical students learn trauma-informed care through this global health practice right here at the UCSF Human Rights Clinic. And here's how the process works. An asylum seeker works with an immigration attorney to prepare their case. And if the attorney thinks it could bolster their claim, they'll place a referral to the UCSF Human Rights Clinic. And then a trained clinician will go on to perform the evaluation and prepare a medical affidavit, which is submitted along with the rest of the case to a judge in immigration court. And on occasion, the clinician will be called to testify in court. So as you can see, this is a medical and legal partnership. And personally, this is the only area of my practice where I've worked so closely with legal colleagues. And the experience has been incredibly rewarding and really shown the impact that we can have when we work outside of our traditional healthcare walls. So we do the evaluations using these tools, and in annual trainings and with ongoing mentorship, we train clinicians who are licensed to use these tools. We use an international framework for the standards and methods of our evaluation. Those are documented in something called the Istanbul Protocol. And we use body diagrams, rulers, forensic photos to document scars. We use the DSM-5 and other psychiatric screeners to document common mental health findings. And at UCSF, along with attorneys and judges, we've actually developed a standard electronic template so that clinicians can jump in and efficiently put together a high-quality affidavit. So what does it look like when we actually do an evaluation? We have 2 medical students here today, and they're going to present a case at the Human Rights Clinic, and they're going to demonstrate very briefly the types of skills used to effectively practice trauma-informed care, which is really our focus with this highly traumatized population. And they're gonna show how we communicate with asylum seekers who have suffered an incredible burden of trauma and come to us in order to document just that. So I'll turn it over to Alice and Nathan.
So we'll now transition to a live demonstration of a typical client-provider interaction. Please note that the items in this case are related to an actual case, but some facts have been changed and de-identified to protect the identity of the client. Some of the topics discussed during this live demonstration will be triggering for some folks. Please feel free to remove yourself from the presentation for about the next 7 minutes if you feel these topics will be triggering for you. For this demonstration, Alice will be taking on the role of the evaluator, and I will be the client.
Hi, my name is Alice, and I'm part of your medical team today. How would you like me to call you?
Nathan?
Nathan, it's nice to meet you, and thank you for being here today. How is it finding your way here?
It was fine.
Awesome. And tell me about what you understand about why you're here today.
I need to come to the doctor before my trial. My lawyer did not tell me much.
Well, that's right. We are a team of doctors. And today we won't be providing medical care because this visit is all about you telling us about your history and the hard things that you've experienced. So I'm here to support you and listen to you and be your witness. We'll work with you and your lawyer on your case. And I want you to know that we are all volunteers and we do not work for your lawyer or for the government or for the judge. What questions do you have about that?
None. That makes sense.
Okay. So for our visit today, with your permission, I'll be doing a full physical exam and taking photographs to add to your report. I'll also be asking you questions about what happened and your feelings about it. Nothing that you tell me will shock me, embarrass me, or make me think any differently towards you. This is a safe place to tell your story, and you can say things that have been hard to share with anyone else. Afterwards, I will write a report and give it and the photographs to your lawyer. I'm also committed to coming to court with you if that would be helpful for you. What questions do you have about that?
None.
Okay. To start, tell me, where were you born?
Eritrea,
And where are you living now?
San Francisco.
Got it. How has living in San Francisco been?
It's okay. I don't know many people here, and I don't like being so far from my family, but at least it feels safe.
Well, I'm glad to hear that you feel safe here. And I'd like to talk more about the things you wrote in your declaration. What was it that led you to leave Eritrea?
Everyone in Eritrea is forced to join the military. My time came when I turned 16. I was in high school and I had to leave everything behind to join the military. Everything got bad from there.
Tell me more.
When you're in the military, you take a test to get out. I did not pass that test and could not leave. Some were allowed to leave the camp, but there were many others like me who were not. And some have to stay there for the rest of their lives.
Could you explain more?
I felt controlled by the government and scared to do anything against them. I wanted to flee, but I had to think about my family. If I tried to leave, the government would threaten to kill me and my family. In my neighborhood, I saw all the families that were taken apart because their family members fled from the military.
I cannot imagine what facing that decision must have been like. You said that you wanted to flee. What was it like for you in the military?
The military kept us in a small living space where I slept side by side on the floor with other men. There were no blankets, no beds. We only ate once every couple of days. And sometimes it was even hard to get some water to drink. I remember one time I was beaten by the officers so badly.
I can see that talking about this really affects you, and it's normal to feel these emotions. Are you okay to continue?
Yeah.
Okay. You said you were beaten by the officers. Tell me more about what happened that day.
One of my friends, he was very sick. I asked for more food for him. But the officers, they came in and they beat me for asking.
Oh, I'm so sorry. How did you feel after that?
Felt so bad. I was bruised everywhere. Felt like I had no choice in life. I sometimes feel that way now. If I am sent back, I know they will find me.
I can see these things are really hard to talk about. Nathan, let's take a moment and take a deep breath together, okay? A deep breath in and out. And put your hands on your knees and your feet on the floor. And let's take another deep breath. And out. We're here in the clinic together, and you're in a safe place now, far from the things that have happened. And we can continue whenever you're ready. You can just tell me when you're ready to begin again.
Okay, everyone. So I now want to recenter us and bring us back into our presentation. Alice will continue the presentation and debrief about the case. If you need a moment, please feel free to take a break and come back when you are ready.
So as we come back from the demonstration, we'll now present what the evaluators found during that evaluation. Multiple scars were seen on physical exam, including on the back, arms, and legs that were highly consistent with the client's account of his physical injuries. And so we documented them using a body diagram that you see on the right here, as well as photos. During the psychological exam, we documented behavioral observations such as dissociative episodes, which are important for the judge to be aware of, as the client may present with these difficulties when testifying in immigration court. We diagnosed PTSD and depression using validated instruments that detect mental health conditions. And at the end of the case, the evaluators concluded that their findings were highly consistent with the persecution that the client described in Eritrea. They submitted the affidavit as evidence in the client's case, and ultimately, this client was granted asylum. Having asylum has meant that his mental health has greatly improved. He now enjoys employment, owns a car, and has been reunited with family from Eritrea, and has hopes to open his own Eritrean food business. During our demonstration, you heard a very difficult story. The evaluator used some very intentional strategies to be mindful of the trauma the client experienced during his journey, and to be effective in documenting the history objectively. So take a brief moment to reflect on what you heard. What trauma-informed interviewing strategies were used? During our own training as students, we learned how to be mindful of trauma in providing an optimal environment to feel as comfortable as possible for the client to tell their story. Many clients have gone through interrogation during torture or have had to recount their story in very stressful situations, like during an interview at the border. And though you couldn't see it here, we are very mindful about creating a welcoming space in our clinic with food, with water, and privacy. We talk through a detailed informed consent, which also helps to create transparency and trust. And when questioning, we try to obtain the history that contains only the relevant details needed in order to avoid flooding the client. We balance empathy with the need to remain objective documenters so that we must recognize bias that may be influencing our questioning. One strategy that helps to maintain objectivity is to use open-ended question strategies rather than leading questions. So during didactic sessions, we practice how to ask questions that help us learn about the client's stories in their own words. We begin by listening and observing, and then diving into the TED questions, tell, explain, describe, which are open-ended questions. We then funnel down to more specific questions to gather more detail. And we reserve closed-ended questions when we require clarification. So we use the following order to ensure we are not biasing the client's story with any of our own preconceptions. And we attempt to give the client as much latitude as possible to tell their story. These are the skills we have gone on to use with many patients, even outside of our human rights clinic.
Thank you, Alice and Nathan. So you just heard about one case from our medical students, and we've now done this for 160 clients since April of 2019. And 86 of our clients received a combined physical and psychological evaluation like the client you just heard about. And 61 had a psych evaluation alone, which we're now conducting virtually. And others had a specialized medical evaluation, like by a neurologist, for example. Clients that we've seen to date have pursued an asylum case based on gang violence, intimate partner violence, political persecution, sexual violence, gender-based violence, and religious persecution. And our clients have come from across 14 different counties of California and have come from countries across the world. The majority of our clients, 75% of them, have come from Central American countries. really reflecting the current political moment. And we see clients that speak a wide variety of languages. Amongst our Central American clients, it's mostly Spanish as well as Indigenous Mayan languages. And through a very generous collaboration with UCSF Interpreter Services, we've been able to offer interpretation at a much higher quality than is normally available for asylum interviews and through attorneys' offices. And what have we found? Well, what we've found and diagnosed is that the burden of trauma in our population of asylum seekers is incredibly high, as expected. On average, an individual client has suffered at least 3 trauma types. We've diagnosed PTSD in 77% of our clients, and many have more than one mental health diagnosis made. 82% of our clients have had physical findings of violence, and 63% have experienced sexual violence, which is incredibly high. So in our first 3 years, we've talked about the 160 evaluations we've done, and these have been done by over 60 clinicians that have come from departments really across the board, from family medicine, internal medicine, OBGYN, pediatrics, emergency medicine, even specialties like rheumatology, neurology, dermatology. And our clinicians have performed on average 3 evaluations. We have a train the trainer model where we've now identified and trained 19 evaluators amongst the faculty to assume roles of peer reviewers and mentors. And then onto our clients. Many of our clients really suffer from this massive backlog in our immigration courts. But of those cases which have been adjudicated to date, 100% of our clients have been granted protected legal status. So that means that nobody that we have touched has been deported. And this rate is higher than the national average. Our students have also been able to provide 1-year longitudinal follow-up for clients to help connect them with mental health, primary care, and social services. So our efforts have not only impacted clients, but also the students and the clinicians that participate. So we've had over 130 medical students. That's a third of the first-year medical student class over the last 3 years, participate in our 11-week elective course to learn the skills to perform a forensic asylum evaluation. And many of them report that they will use these skills in their future clinical practice and will expand the pipeline of clinicians who know how to complete forensic documentation of human rights abuses in their career. And these quotes show that students better understand the experience of asylum seekers in our country. They're more likely to work with immigrant and refugee populations and use the skills of trauma-informed care, like those you saw demonstrated today, to inject compassion and empathy into their practice universally, no matter what profession or specialty they pursue. And what we've learned is that our trainees, whether medical students or global health master's students, are motivated to learn and to take action on issues of migration locally. And they're motivated by their own family or personal histories of migration, by their early exposures to work or volunteer experiences in global health, and by the recognition that the issues of human rights and migration and climate and health justice are the issues of relevance to their future careers. So here are the faces of nearly 30 medical student leaders who've spearheaded the Human Rights Clinic. And all of them, 100%, like Alice and Nathan, have sustained their involvement throughout every year of medical school. And we've been building the Health and Human Rights Initiative around this asylum work with a team of faculty leaders that you see here. And so you've heard today about how we perform these evaluations for adults and children in the Bay Area, but I also want to present how our work has national and global reach. So at the Health and Human Rights Initiative, we have several educational programs. You've heard we've trained our 60 clinicians in our clinic, but we've trained hundreds of clinicians in national and international trainings. You heard today about our medical student elective, but I want to highlight that we're also training other learners, like the Global Health Master's students who may be on this Zoom. And this year, we're also launching a track in the HEAL Global Health Fellowship, as well as rotations for residents and fellows and several clinical rotations. In August, we'll launch the first peer-reviewed national online training curriculum on forensic asylum evaluations. And these kinds of skills, these unique skills in documenting human rights abuses that we learn here locally, also translate to the international context. So for example, I will be taking skills honed here in San Francisco to train Syrian doctors in documentation of human rights abuses in the Middle East this fall. The Health and Human Rights Initiative has several projects and publications underway to disseminate about the trends that we document through our work for a very understudied population. And we've designed a novel electronic documentation tool that allows for data capture and analysis from our forensic evaluations that can help address these major research gaps. And lastly, we're partnering with organizations like the UC Hastings Center for Gender and Refugee Studies to use our voices as healthcare professionals to advocate to improve migration and public health policy for asylum seekers. So we have reached the end of our presentation. And in summary, today you've heard from us at the Health and Human Rights Initiative about how we're connecting the global issues of migration to the local context. And we're involving trainees and really leveraging the power of being at an academic institution at UCSF. And we hope that we've met our objective to expand your awareness of how asylum medicine fits into global health. And hopefully many of you will want to partner and extend our impact. We've talked about some very difficult things today, and you heard a very difficult story during the demonstration. So we want to end on a hopeful note, grounded in the words of our clients. And we'll close with some quotes from our asylum-seeking clients who've traversed a long journey to make it to our clinic in pursuit of safety and health. They say, "I feel free. I am finally safe. I'm in a land where the law matters. For the first time, I have hope. This is the next step in a long journey." Thank you so much. And please reach out to us if you'd like to learn more. And we're happy to take questions.
So we have a question in the Q&A that I can read out loud for you right now. I know that you touched on this a little bit in your presentation, but we have a question that says, what are the demographics of the population you serve? I wonder how shifting global political events change who you see. For example, Central Americans who are victims of longstanding violence versus war refugees.
It's a great question. So as you heard, the majority of our clients have been Central American clients, about 75%, which I think is definitely a reflection of our location in California and of the current immigration policies and politics of the Central American region. That has shifted over time. If you look at equivalent asylum clinics several years ago or on the East Coast, I would say they were more typically seeing folks from Africa, for example, who were fleeing political persecution. And what we're seeing right now is quite different. I'd say our typical client is a Central American woman. 62% of our clients are female, identify as female. And she is fleeing a combination of types of abuses related to domestic violence, gang violence, and often persecution related to Indigenous identity. So that is a very typical client for us at this time, and is definitely a reflection of the political moment. The other thing that I think affects the demographics of our client base are the relationships that we have with attorneys and legal organizations. So there's some immigration attorneys who work or specialize with a specific population. For example, take care of Eritrean asylum seekers. And based on those relationships, you'll get a lot of referrals from that one attorney. And we really do try to work with attorneys that we have a trusting and knowing relationship with. So that's the other thing that I think impacts our demographics.
Thank you. And we have another one. They would like you to explain the role of documenting their medical conditions and getting asylum approval. Yeah.
Sorry, could you just clarify that question a little bit more?
Yeah, they would like to know more about the role of the actual documentation process for the medical conditions that the asylum seekers have, and what the role of that is in actually convincing the judge to get them legal status.
So there is a very substantial dialogue between a clinician who is documenting and an attorney. And I would say it's a very free-flowing relationship where we prepare ahead of the case in talking to the attorney about exactly how they want us to fit into the evidence. Because we are just a part of the evidence that's used in a case. So we prepare ahead of time. We talk about why is this person seeking asylum? What is the legal context of the case? Where should I focus my time as a clinician? And so there's that in preparation. And then there's dialogue after the case in the editing process of an affidavit. So we will go back and forth usually several times with an attorney editing. And it is a careful balance between maintaining your expertise and objectivity as a clinician and only writing what you can attest to, while also being able to strategically present material. So a good example is, there are certain details that a client will give, especially if they have PTSD or their memory has been impacted by really terrible things they've gone through, where a client may tell you a very small detail that's ever so slightly different than what they wrote in their declaration with the attorney, and could be ever so slightly different than what they say to an immigration judge. And so a lawyer may have feedback of, this particular detail isn't central, maybe leave it out. There's just a lot of dialogue like that we go through. Once it gets to the point of the judge, there isn't necessarily dialogue unless the clinician is in the room testifying, in which case the judge can ask questions. When an asylum, there's a question about what if asylum is denied or there's an appeal process. There is an appeal process, and it's possible that an attorney may have a clinician fit into that in some way. But if asylum is denied or a patient, there are folks that are deported right from the courtroom. And so in some cases, there isn't an opportunity for appeal. And then, sorry, in that question, I see a really interesting point about how this strikes as similar to the early HIV epidemic in San Francisco with the psychological scars. And it is actually really interesting to think about the exclusionary immigration policies earlier, and actually not so long ago in the HIV epidemic, and how today we continue to see exclusionary immigration policies that are based on race and a number of other factors. And how HIV advocates during the epidemic successfully advocated to reverse some of those xenophobic policies. Nathan, I see your hand up if you want to add to that.
Yeah, and just along the lines of the medical conditions as well, we didn't get a chance to touch on this during the presentation, but for an example of the case that we discussed, that client was in the US for several years and was not able to file an appeal for asylum within the 1-year filing deadline that you're required to file your asylum case when you arrive to the United States. And a way to kind of get an exemption for not being able to file within the 1-year deadline is to present a medical reason, such as like PTSD or a psychological reason. And doing a forensic medical evaluation allows to provide for evidence in the courtroom that these are the reasons why the client was not able to, ascertain an asylum application within the given timeline. So that's another important reason for why we document medical conditions in support of clients' cases.
Thank you. We do have another question. How are you connected to a client? Are they seeking you out actively or do you reach out to them?
Great question. Because I think so often, I'm also a primary care doctor at San Francisco General Hospital, where I see a lot of our clients in a different context, and taking care of them as patients. And so many times clinicians come up to me and say, I have a patient, I think that they could qualify for asylum. Can you do something? And really the answer is a person needs to be connected to an attorney. And I'll let Alice finish this because my dog is. Okay, I'll take over again. A referral has to come from an attorney who can actually weigh in on what it is we need to accomplish in an evaluation that contributes to the client's case. And there is a huge shortage of immigration attorneys. They, just like we in healthcare, face massive rates of burnout. Immigration attorneys, and it's been well documented in the literature, also face a lot of burnout and turnover. And oftentimes when an immigrant is seeking out an attorney, it's very difficult to find somebody who will represent them. So there's definitely a bottleneck there as well.
Thank you. And we have one more. I'm wondering how you all speak to inconsistencies in client testimonies or limited emotional effect of client as a product of trauma. Do you find that the court's standards for credibility are trauma-informed?
It's a great question. A huge role of the forensic documenter, the clinician, is actually to educate adjudicators and educate judges on what are the impacts of trauma on somebody's mental and physical health, and on their behaviors, and on the way that they interact and present themselves. And so just like Nathan and Alice described in that case, and Nathan was sort of trying to act out some of it, which you may have picked up on, but a difficulty retelling a story or remembering details of a history is often the impact of PTSD, of traumatic brain injury, and of trauma. And there's really an increasing evidence base that shows the high rates of PTSD, of memory issues, and of traumatic brain injury in our very asylum-seeking population. And so we're really trying to educate judges on the fact that people are acting the way that they act and retelling their story often because of the impacts of trauma and not because they're lying. By the time cases make it to us through a trusted attorney, they've usually been screened, and these are all very credible clients that we're seeing. And so we're able to attest to that. We can't make a determination about a client's credibility. That's a legal determination, but we can describe their affect. We can describe their mental status exam and how they look and present in our many hours of evaluating them. And we really detail that because it helps a lot when that's how they're acting in the courtroom.
Before we close out, let me ask one question, if I may. Since I'm a panelist, I can't get to the Q&A, I'm sorry. How many of these are there in clinics like this are there in California? Is there a need for more, or is there, or are we oversubscribed, or just kind of give us an idea of what the workload looks like and whether there's room for more?
It's a great question. There is a huge need for more. As you can see, it makes such a difference to a single case to have the medical exam, particularly when there's physical findings. People are just granted asylum at a much higher rate. So you could argue that every single person coming in this country should really be having an evaluation like this. We are really a drop in the bucket. The need, right now in San Francisco, there are over 75,000 pending asylum cases, and in California, that's much greater. So we drastically need to increase our pipeline of trained clinicians. That's why we're training all of these incredible medical students and master's students and others. And we need more space, we need more resources, and we could do a lot more. In California, there are clinics that are primarily based at academic centers, as I said. So the UCs, UCSF, UCLA, and UCSD have pretty robust clinics. There's a lot of places that want to start clinics. So for example, we're helping UC Davis to start their clinic, and our medical students are actually on a national board that helps clinics all over the country to pop up. And we're trying to collaborate with the other UCs so that we can create a more robust network. We can share our data, we can work together, we can train. I mean, right now I'm peer reviewing and training folks at UC Davis so that they can get started. So the need is huge. And I think that we could do a lot to expand our efforts across the state.
Thank you. Well, in the absence of additional questions, correct? Let me thank you again, along with Alice and Nathan. Thank you guys very much. This has been really eye-opening and a tremendous experience to relate for all our for everyone attending today. And good luck with your work. Don't be a stranger if there's anything we can do for you. And for the rest of you, we'll see you back on September 14th, same time, same station, in person, ideally. Thanks again very much. Thank you, Triveni.